look at primarily the antacids, gastric hyperacidity, and then the hydrochloric acid should give you a good understanding of what's going on in this chapter. So when we're really taking it back to the A&P, one of the conditions of the stomach that requires drug therapy is hyperacidity. We usually have hyperacidity more than alkalosis. That's when I have excessive acid production. If that's left untreated, it can lead to serious conditions such as acid reflux or ulcer disease, esophageal damage, and even esophageal cancer. Overproduction of this stomach acid is referred to as that gastric hyperacidity, which we mentioned. Lots of different cells depicted in figure 50.1, which is right here, kind of giving you an idea of what the different cells in the GI tract do for us, specifically the stomach. It talks a little bit about the parietal cells versus the gastric cells. So think about the parietal cells producing and secreting that hydrochloric acid, and then those mucus cells secreting mucus that really coat that stomach, that GI tract. It serves as that lining to prevent the acid from eating in through the stomach itself. When we get down to our medications here, our first one that we're looking at are antacids that neutralize stomach acid. Most commonly, these are over the counter, so they're non-prescription strength, and they use either aluminum, magnesium, calcium, and or sodium. We've used it for an extensive amount of time to treat acid-related disorders. When you think about these, remember when we talked in respiratory, we mentioned H1 receptor antagonists, and I wanted you to think of the one as respiratory, like your trachea. On this one, we're talking about histamine 2 receptor blocker, so think about histamine 2 being separate from that histamine 1 blocker. So when we're looking at these, our antacids, I think of the medications in this chapter as going from the most calm to the most severe. So our most, I guess, calm or the least the least strong ones would be our antacids, and they work by just neutralizing that gastric acidity. They don't do anything to prevent the overproduction of the acid. They just help neutralize those secretions. Those indications are for acute relief, so quick relief of peptic ulcer, gastritis, hyperacidity, and heartburn. Our contraindications are known to be allergy, drug allergies, renal failure, and electrolyte disorders. Adverse effects that we get from these acid-controlling antacids would be if they're magnesium-based, they can cause diarrhea. If they're aluminum and calcium-based, they can cause constipation. If they are calcium-based, they can cause kidney stones. And if they're just aluminum-based, they can cause hypercalcemia. So memorize those, what the different bases can cause, because sometimes we might use those to treat that problem, such as if I had a problem with constipation, I might use magnesium to help me get over constipation. Just the flip side, if I'm having diarrhea, I might use aluminum to prevent me from having diarrhea. Also, they can cause systemic alkalosis and some rebound hyperacidity, so we want to minimize the use, take it only as needed, and not to overextend on that one. One of the things we want to make sure that if we are taking antacids, that we're not hiding an underlying problem. So with any of the medications in this chapter, if they take the medication for a long period of time, we want to make sure they're following up with the healthcare provider to make sure we're not masking an underlying problem. Great table, 50.1, that mentions some of the interactions. Antacids can cause adsorption of other drugs, which reduces the ability of that other drug to be utilized. It can also cause chelation, which is the chemical inactivation of other drugs. And then it can increase stomach pH, which increases the absorption of basic drugs and decreases the absorption of acidic drugs. It can also increase urinary pH. Some special notes with our antacids. Scroll down a little bit. Some special notes to be aware of is they can cause hypercalcemia, so understand the signs of early hypercalcemia, which would be constipation, headache, increased thirst, dry mouth, decreased appetite, irritability, and a metallic taste in the mouth, whereas later signs and symptoms of hypercalcemia could include confusion, drowsiness, an increase in blood pressure, irregular heart rate, nausea, vomiting, and increased urination. We can also see signs and symptoms of alkalosis if we've taken too much of the antacids, which could cause irritability, muscle twitching, numbness and tingling, some cyanosis, slow and shallow respirations, headache, thirst, and nausea. That's fairly significant if someone comes in and says they've been eating antacids nonstop. To look at our three different ones here, we're going to look at aluminum and sodium-based antacids are also often recommended for patients with renal compromise because they're more easily excreted than the other categories. Our calcium-containing antacids are an excellent source of calcium, so we might have individuals that have osteoporosis, might take calcium-containing antacids. However, because they cause neutralization in the stomach, they can cause gas and possibly belching. So frequently, we will give that one. We'll combine it with an anti-flatulent drug called simethicone to decrease that gas and belching. Our magnesium-containing antacids can produce a laxative effect, and frequent administration of these antacids alone often cannot be tolerated. Then both the calcium and magnesium-based antacids are more likely to accumulate to toxic level in patients with renal disease and are often avoided in patients in that patient group. My next group, so moving up in, I guess, severity or the strength of the medication, would be my H2 receptor blockers. These are my prototypical acid secretion antagonists. They reduce but don't completely abolish acid secretions. They become very popular in the treatment of acid-related disorders, including peptic ulcer disease. These medications inhibit the acid production and increase the pH of the stomach, so I think it's making it more alkaline. Indications would include GERD, peptic ulcer disease, erosive esophagitis, adjunct therapy for the control of upper GI bleeding. We can also use them for stress ulcer prophylaxis in critically ill patients. Contraindications are drug allergies, and there's a good table, 50.2, that lists some of our adverse reactions or adverse effects. And then to note, we have two medications here. Our cimetidine or Tagamet was the first prototypical H2 receptor blocker antagonist, and then we have phenadimine, which is Pepcid, and that's has very few drug interactions, so it's widely used. It's available in oral and injectable forms. I dare say you'll give both of these fairly commonly in the hospital setting. Then our last one, which I really have a love-hate relationship with, on our proton pump inhibitors, they actually they bind to that hydrogen potassium ATP pump, and they inhibit the action of that enzyme, which results in total blockage of hydrogen ion secretion from the parietal cells. So when I block that completely, it's going to, it can up to 90% block those secretions over a 24-hour period, which puts patients in an alkalotic state. That can cause complications such as bacterial overgrowth, intestinal metaplasia, and hip fracture. However, food absorption is usually not affected from this because we've got the entire GI tract to absorb food. The indications for this is more severe when I have erosive esophagitis, symptomatic GERD that hasn't been receptive to either my antacids or my H2 receptor antagonist. Also, if I have some short-term treatment for duodenal ulcers or active benign gastric ulcers, or if I have a patient who's had gastric hypersecretion conditions. Also can use it for stress ulcer prophylaxis. And the contraindications would be drug allergies, and there are a few adverse effects. They're usually well tolerated, but some of the adverse effects can predispose patients to GI tract infections. So keep that in mind with that one. PPIs also speed up bone mineral loss, so there's a warning to watch that with individuals, specifically who are at risk for uh, hip, wrist, and spine fracture. Um, that would be my big one. And then interactions would be it increases diazepam and phenytoin levels and increased bleeding or efficacy of warfarin to lead with bleeding. So teaching would be important for both of those. My drugs of choice for this one is omeprazole. Omeprazole was the first drug in this breakthrough class. There are other ones such as Nexium and Prevacid. Um, these are usually orally administered PPIs. They work best when taken within 30 to 60 minutes before a meal. They can also be available in intravenous administration for use, typically with prophylactic patients in ICU ward to prevent them from having a gastric ulcer. Also can see lansoprazole. This one is a delayed release capsule. It is orally disintegrating, so because it's a capsule, we don't want individuals to open it or crush it if possible. We would like them to take the whole thing so it can be released as they need to. But if they're unable to swallow the whole capsule, it can be taken. It can be opened and put in apple juice or something for like a NG tube administration. The third medication there is pantoprazole, which is the first PPI we use for intravenous use. We can use it continuous infusion also for the treatment of GI bleeding, and then it's also available in oral form. We can in the oral form. The granules are very large, so we must have, if we put it down at NG2, we have to make sure that that's at least a size 16 or the granules can clog up the tube. There's a couple of miscellaneous at the end of this chapter. Sucralfate is one of them, and then the simethicone. On the sucralfate, that's the caraphate that's used as a mucosal protectorant of the GI tract, so it doesn't work systemically, it works locally, and it will directly bind to the surface of a gastric ulcer. And then that second one is the simethicone, which is anti-gas. We get that with in babies that are colicky all the time. So on that simethicone, it just helps to decrease that gas so that the bloating is significantly less. On assessment of these, we want to make sure that before we're giving an assessment, acid controlling drug, that we do a thorough assessment to figure out what's going on with that patient, making sure we pay attention to hepatic function and renal function, understanding that aluminum causing antacids are used can cause constipation, whereas magnesium containing ones can lead to diarrhea. Calcium based ones, although they are a good source of calcium, can also lead to rebound hyperacidity. And then our sodium bicarb is generally not recommended for an antacid because it has a high risk for systemic electrolyte disturbances and throwing that patient into alkalosis. When we use the H2 receptor antagonists, we want to make sure they have good renal and liver function as well as their level of consciousness. Older adults are known to react with these drugs with disorientation and confusion. We want to make sure that if we give multiple drugs in this class with antacids, that we space them at least an hour apart. And then for our PPIs, we want to make sure that we assess for swallowing and for drug allergies, specifically with that diazepam, phenytoin, warfarin, and even antibiotics of ampicillin. With other GI-related medications such as that simethicone, we want to assess for abdominal distension and rigidity and their ability to pass gas or flatus. Then with implementation, when we're taking if they're using chewable acid control drugs, we want them to thoroughly chew those tablets. If they're antacids, they should be given with at at least 8 ounces of water to enhance that absorption of the antacid. We want to avoid giving them within 1 to 2 hours of other medication. Note that if it's intravenous H2 receptor antagonist, that we can have some hypotension with rapid infusion, so slowing that down as we're giving it would be important. And then monitor for that